Hello everybody, my name is Heather Brown. I'm a registered nurse and instructor with Gurnick Academy of Medical Arts. This presentation will be for our nutrition course and be on Chapter 19, Coronary Heart Disease and Hypertension. So right now you're getting a lot of cardiac between nutrition and A&P. You learn about cardiac for a week or two, so hopefully this helps you in your other courses. So this chapter is going to discuss the primary underlying disease process of atherosclerosis, as well as hypertension and the various risk factors involved. So we're going to be going into this. Hope you guys all enjoy this lecture. Here's our introduction slide for lesson 19.1 on cardiovascular disease. So cardiovascular disease, or CVD, is the leading cause of death in the United States. Several risk factors contribute to the development of coronary heart disease and hypertension, many of which are preventable by improved diet and lifestyle behaviors. Other risk factors are non-modifiable, such as age, gender, family history, and race. Coronary heart disease. So this is the leading cause of death in the United States, like I previously mentioned. There's more than 611,000 deaths each year. Similar in other Western developed nations, and more than 1 million live with various forms of rheumatic and congestive heart disease. So I don't need you to memorize the numbers for this slide. We're just trying to illustrate that it's a major problem not only here, but around the world. Atherosclerosis. So this is where fatty fibrous plaques, okay, this is the hard junk that sits inside the lining of major blood vessels. So fatty fibrous plaques, largely composed of cholesterol, develop on the inside lining of major blood vessels. It narrows the interior part of the blood vessel. If affected vessel is a major artery supplying the heart muscle, it can result in a myocardial infarction, or an MI. That's what you guys might more commonly known as a heart attack. So a myocardial infarction is a heart attack. In the medical world, we refer to it as an MI. And a local area of dead tissue is an infarct. So depending on which vessel has this atherosclerosis, it can in fact cause a blockage depending on how much plaque is there and other risk factors. So I will be showing you this in a picture on an upcoming slide, guys, but we're connecting that a myocardial infarction and MI, this is a heart attack, and atherosclerosis and these plaques that build up contribute to that. So common symptom is angina pectoris, or chest pain, usually radiating down the arm, sometimes brought on by excitement or physical effort. So you get more pain when you need more oxygen. So when people are usually exercising or doing something and they need more oxygen and they have those narrow passageways, they're not getting the oxygen they need, and then usually it leads to angina pectoris or chest pain. If the affected vessel is a major artery supplying the brain, the result could be a cerebrovascular accident, or CVA. So a CVA, you might know it more commonly as a stroke. So MI is a heart attack. We're going to refer to it as a myocardial infarction. And a CVA is a stroke or a cerebrovascular accident. All right, guys, so now we're looking at that plaque, okay, that atherosclerosis. So on the left, we have a normal artery. It's nice and open, okay? It's like an open roadway. There's nothing blocking it. It's nice and open. It's patent, and it's allowing for good blood flow. Now, the picture on the right, we see that plaque buildup. So what we have there is less of an opening, so more of a difficult time for blood to flow well. If that plaque was to really, really build up, there would be less and less room. So on the left, there is the only area that blood's allowed to flow. So it's filled up with lots and lots of plaque, which is really affecting the blood flow. So remember that I said if this occurred in the heart and ended up blocked, we'd have a myocardial infarction. The same thing if we blocked one of these vessels in our brain, that's where we could have a CVA or a stroke. And if we blocked a vessel in our leg, that's where we could have a DVT or a deep vein thrombosis. So kind of depends on where the blockage is formed, and that's kind of how we describe it by one of those main diagnoses. Key terms. So we have myocardial infarction, remember MI, a heart attack. We have a CVA or a cerebrovascular accident, that's a stroke. Coronary heart disease, which on introduction, we went over some of the statistics showing you what a problem it is for us. Angina pectoris, that's chest pain. It can be associated when those vessels have lots of plaque. We have a disruption of blood flow, a disruption of oxygen being sent places, which is going to lead to chest pain. And then lastly, lipids, which we're going to be looking at some labs in some upcoming slides and breaking down lipids and how they play a role as well. So now we're going to be talking about relation to fat metabolism. So think back when we went over our macronutrients and we talked about fat. And now we're going to be looking at the 3 lipids that are relevant to cardiovascular disease. Okay, so the lipids that impact the heart. So we have total cholesterol. This is fat-related compound produced in the body, also in foods from animals. So total cholesterol. Now, if the total cholesterol is high, see how we're adding hyper. So hypercholesterolemia, sorry, that's tough and I would re-record, but it's probably not going to get better. So high cholesterol. So we see that root there, and we see it added to cholesterol, and we're having high blood cholesterol levels. Lipoproteins, these are essentially little packages. They're wrapped with a protein that carry fat in the bloodstream. So dyslipidemia, this is abnormal lipid profile. So dyslipidemia. And then lastly, we see triglycerides. These are simple fats in body or food. So we can have a high level of that too. So we have hypertriglyceridemia. So that's high blood triglyceride levels. So this is common with high levels of low-density lipoproteins. And we're going to go into HDLs and LDLs, or low-density lipoproteins, next. So these are 3 lipids relevant to cardiovascular disease. We see it in cholesterol, in the lipoproteins, and also in triglycerides. All right, so these are types of the lipoproteins. So right where we left off on the previous slide, and I said the low density lipoproteins that we'd go into. So here we're seeing the very low density lipoproteins known as the VLDLs, the low density lipoproteins known as the LDLs, and the high density lipoproteins, or the HDLs. Now the way I remember this is in the middle we see low density lipoproteins. When I was taught about this, low density lipoproteins, these are the bad ones. Okay, so LDL is bad. It's low down dirty. It is bad. On the opposite side, high density lipoproteins, these are the happy ones. These are the good ones. You want a high level of HDLs. It's the good one. So we want our HDLs to be high. It's happy. We want it high. And we want the LDLs, or the low density lipoproteins, to be low. Then we have the very low density lipoproteins. So these are formed in the liver from exogenous fat, and they carry a large load of triglycerides. So these are even worse. They're very low down dirty. So these are the worst. And then we see the low density lipoproteins, or LDLs. And then next we see the high density lipoproteins, or HDLs. That's our good. We want our HDLs to be high. So these carry less total fat and more protein than other lipoproteins. So this is my good cholesterol. So if you've ever been to the doctor and they say your good cholesterol level is low, he's talking about your HDL. Or if they say, oh, that's great, your good cholesterol is nice and high. So they're referring to your HDL levels. So let's look at some risk factors for cardiovascular disease. So gender's 1. Cardiovascular disease is more common in men until women reach menopause. So before menopause, women are protected by hormones, and when they reach menopause and those hormone levels switch, that's when we're seeing that they're more common. So until that point, it's more common in men. Age, so risk increases with age. Also family history. So think about your family and how much family history you have of cardiovascular disease. If you have extensive, then that's a major risk factor. So it just depends on how many relatives you have with cardiovascular disease and the extent of which they had it. Heredity, so certain ethnic groups are more prone to it. They might have a family history of high cholesterol or high triglycerides. And they also want to look at your blood cholesterol levels. So risk factors include a high total and LDL. Remember, LDL is low down dirty. That one's bad. You don't want it to be high. You want it to be low. So if you had a high LDL, that is bad. And you want a high you want a high HDL. So if the HDL is low, that is bad. So you want your HDL, your happy cholesterol, your good cholesterol to be high. And you want your low down dirty, your bad one, to be low. The other cholesterol they're mentioning here is total cholesterol. You want that to be low as well. So if it's high, that's definitely a risk factor. So some compounding conditions, things that make this all worse, is type 2 diabetes, as well as hypertension, and if there's a metabolic syndrome that's present. So a risk factors some can be controlled and some can't be controlled. So some things that we can control is like lack of exercise. Somebody might not exercise much, but they do have control over the ability to exercise more. Something else that they could control would be, say, smoking. So smoking causes vasoconstriction. Those blood vessels actually constrict and become more narrow. Add that with lots of plaque, and already a blocked road becomes more blocked. So something like smoking, which causes vasoconstriction, that could be modified. Somebody could quit smoking. But something like family history, you can't modify that. Whatever's present in your family is just what it is. You're not able to modify. So there's definitely modifiable things and different things on this page that you can't modify. So like age, you can't change your age. So that's modifiable versus conditions that cannot be modified. All right, guys, now we're going to be looking at a case study. So we're going to utilize this case study throughout this presentation. So Mr. Elliott is our patient. So he's a 68-year-old male who is referred to the dietitian for a fat-controlled meal plan. Mr. Elliott is 5 foot 10 inches tall and weighs 250 pounds. His blood pressure is 155/95. Recent labs reveal a total cholesterol of 245, a LDL of 171, an HDL of 36, and triglycerides of 200. So this is the initial information we have for Mr. Elliott. So I want you to start thinking about what factors here are relevant for Mr. Elliott to potentially have coronary heart disease. So we're seeing that he is overweight. We're seeing that he's a little advanced in age. He's 68 years old. We're seeing his blood pressure is high. Then we're also seeing some labs. So his HDL is low. Remember, that's our happy, that's our good cholesterol. We want that to be high. They usually set the benchmark for that to be 50. So they want the patients to have an HDL higher than 50 because it helps protect against heart problems. And then we're seeing an LDL that's elevated, a total cholesterol that's elevated, and triglycerides that are elevated. So he's got a couple things that he's working against here. We are going to be looking at some additional information in the upcoming slides. So remember Mr. Elliott for this next set of slides. All right, so list Mr. Elliott's risk factors for heart disease. So if you need to, pause your video so that way you can think about this before I shout out the answer. So some of his risk factors include his gender. So remember, it's more common in men until women hit menopause. So he's got that as a risk factor. His age, he was 68 years old. He's got some compounding factors, so some things working against him as well, like hypertension and that he's overweight. And he also had those elevated blood cholesterol levels that we previously mentioned on the last slide. So the things that he can modify, though, is he could change those cholesterol numbers if he changed his diet. So that's something that he could modify. So which risk factors can be modified? Definitely his cholesterol profile with work could be modified. He could also work on modifying his compounding factors. So he could change his weight. He could also improve his blood pressure. Those are things that he could modify. And lastly here, what additional information would be helpful to look at risk factors? So additional information I would be curious about would be what's his family history? So did anybody in his family have heart disease? Who was it? Did he have several family members with heart disease? I'd also want to know, is he a smoker? Because remember I said smoking causes those blood vessels to narrow even more, putting the patient at higher risk. So I'm concerned, is Mr. Elliott a smoker? That would be another question. And then he's there for a dietitian consult. So I'd be curious what his daily food patterns are like. Those are just some of the initial additional information I would be very curious about. All right, so let's keep working with Mr. Elliott. What other lab value and assessment data would you consider in assessing Mr. Elliott? So what other labs are you curious about? So the one that comes to my mind is maybe a fasting blood sugar or a fasting glucose, because I'm curious, does he maybe have diabetes too? He is overweight, he is advanced in age, he has some of those risk factors that go hand in hand with diabetes. We also saw he had hypertension. So I would be curious what his fasting blood glucose was or blood sugar. Remember, when we check blood sugar, if we checked it when he was not fasting, if he just ate, or if he ate a few hours ago, we'd have no idea if that blood sugar helped us or not. So we'd want it to be a fasting blood sugar to see how his body does after a period of not eating, how his body's functioning. Another lab that I might be interested in would be the hemoglobin A1C. So this is a lab that trends blood sugars over several months, and this lab could maybe tell me, does this patient usually have elevated blood sugars? It's used to potentially diagnose with diabetes. So some labs I'd be interested in would be the fasting glucose. I'd also maybe be interested in a hemoglobin A1C. So those are some labs that I'd be interested in. Now, what about assessment-wise? So when we're assessing this patient, what might you consider? So let's think about this. We could look at things like his BMI and see where he is as far as, is he obese? Is he morbidly obese? What category does he fall in? Something else that we could assess would maybe be his waist circumference. Depending on that result, it puts patients at greater risk for CVD issues. So that's just some initial information that we'd want to consider assessing. All right, so let's talk about a healthy diet. These are not to be memorized. It's just to illustrate general amounts. You guys might not follow this, and this is not individualized, so this is just general information not to be memorized. So greater than or equal to 4.5 cups per day of fruits and veggies, greater than or equal to 2 servings a week of fish, greater than or equal to 3 servings per day of whole grains. We want to have less than 36 ounces a week of sugar-sweetened beverages and less than 1,500 milligrams per day of sodium. The American Heart Association notes that poor diet is the #1 risk factor for death and disability in the United States. So that's a big deal, right? The American Heart Association notes that poor diet is the #1 risk factor for death and disability. So right now, as you guys are listening to the lecture, this is also the same day that we have you turn in your nutrition project. So you've been kind of examining the foods that you eat. Remember, our goal here isn't to change you, to just help you identify the foods that you're eating to be able to categorize them. So here we're just looking at a general outline for a healthy diet. And I'm also kind of bringing in the nutrition project because hopefully you've kind of seen some trends in yourself and you can utilize that information and what you've learned to potentially one day help your patients. Here's some additional dietary recommendations. So dietary recommendations for reduced risk. So this includes reduced fat and cholesterol. So we talked about how we want to keep our cholesterol down. We want to reduce our fat and possibly therapeutic lifestyle changes. So this may include appropriate weight, so potentially weight loss, potentially diets, increasing activity. So we see more physical activity, and control other risk factors. So I mentioned smoking. That's something that's controllable. So potentially stopping smoking. Lifestyle management guidelines. So diet, more emphasis here on diet. So we want to emphasize vegetables, fruits, and whole grains, low-fat dairy products, poultry, fish, legumes, non-tropical vegetable oils, and nuts. We want to limit things like sodium, sweets, sugary beverages, and red meats. And we want to adapt to calorie requirements. So remember, if you're taking in a lot and you're not using as many calories, you're going to gain weight. If you're taking in less and you exercise more or you burn more calories, you're going to lose weight. So patients might need to adapt to calorie requirements. If their body only requires a certain amount, then maybe they need to adapt so that they're only taking in that certain amount. There's also personal and cultural preferences. People are just going to have a lot of previous experience with the foods that they like to eat. They have cultural preferences as well. So we want to be very mindful that this isn't one size fits all. These are just some general guidelines, but it's not going to fit all of our patients. Medical nutrition therapy for other conditions. So depending if the person has other conditions, we might see different nutrition therapy needed. So a food choice, if we're trying to guide our patients about controlling fat and cholesterol, remember what type of foods are highest in cholesterol. So our animal source foods. So if we're trying to educate our patient on keeping their cholesterol levels down, they want to avoid those animal sources. So that's a very good teaching point for our patients. And then on the bottom, we see exercise. So 150 minutes per week of moderate intensity aerobic physical activity, or 75 at vigorous intensity. Now, as a nurse, you're going to be teaching patients, and honestly, not everyone's going to start at 150 minutes per week. And we can encourage our patients just to start with very light walking. And just start walking, just start moving, and you'll get there. And just really be encouraging to them. And remember, not everyone's going to start at that big of a pace. They might start much slower, and that's okay. We just want to support them in their process. So more on diet therapy here. So for patients who would benefit from a lower LDL, remember LDL is bad, we want it to be lower. So for people who could benefit from a lower LDL, we want to reduce the total percentage of calories from saturated fat. We want to aim for 5 to 6% of calories from saturated fat. So the greatest proportion of dietary fatty acids should be unsaturated. So I'll repeat that. The greatest proportion of dietary fatty acids should be unsaturated. So we want to reduce percentages of calories from trans fat. 3 to 4 sessions of aerobic physical activity per week, lasting 40 minutes each of moderate to vigorous intensity. Remember, this is going to be different for your patients. And drug therapy. Drug therapy is initiated depending on risk factors. So depending on all of those different things we've discussed, it is potential that drug therapy would be utilized. So here we're going to discuss some interventions that could assist Mr. Elliott in reducing his cardiovascular risk. So let's think about it. Think back to Mr. Elliott. So some things that he could do is he could aim for weight loss. So he was, I believe, 250 pounds. He could initiate a diet. He could increase his physical activity slowly at first, depending on what he's able to do. And then remember, we were going to assess for other risk factors like smoking. So if he was a smoker, we could help him modify that, encourage him to modify and stop smoking. So these are some interventions that could assist Mr. Elliott for reducing his cardiovascular risk. These are just some of them. You guys might be thinking of additional ones at home, and that's great. So this is just some basics. So now we're going to be looking at acute cardiovascular disease, specifically myocardial infarction, MI, or heart attack. So the objective, cardiac arrest. So this includes analgesics or things that address pain. So if your patient has a heart attack, what we're going to want to encourage right in the period afterwards is cardiac rest. So we want the heart to be able to heal. So energy restriction reduces metabolism and therefore reduces workload on the heart. So we want the heart to be able to rest. So we can do this by reducing energy intake. So allow that heart to rest by reducing energy intake. So principles of medical nutrition therapy. So our goals are to promote recovery and strength and lower that LDL. Remember, LDL is low down dirty. It's our bad cholesterol. We want it lower. So immediate energy intake reduced to reduce load on the heart. So I mentioned that we want to reduce that energy intake. That way the heart has less stress and less work to do. We want a soft or easily digested foods. So this is not the time for a big T-bone steak or anything like that. We want less work on the heart, less work on the body. So we want soft and easy to digest foods. Now long term, the patient may want to consider a Mediterranean type diet. So Mediterranean type diet is high in fish. So Mediterranean diet high in fish, we have a higher HDL diet. And remember, HDL is protective for the heart. It's our good cholesterol. Some other things that are part of the Mediterranean diet are plant-based foods like nuts and whole grains. So this is another positive for a Mediterranean type diet. We'd also want our patient to limit sodium. So when we're educating them on preparing food, they can no longer prepare food maybe drenched in soy sauce or barbecue sauce. We'd want to educate our patient that something like lemon juice can now be used as an alternative to those more salty type of seasonings. So lots of education here for these patients. So now we're going to switch tunes to heart failure. So congestive heart failure, this is an inability to maintain adequate cardiac output. So the heart basically can't keep up. It's just a fancy way the heart can no longer keep up. It's essentially drowning, congested. So it can't keep up anymore. So the objective, we want to control the pulmonary edema. So what we're going to have is a lot of swelling because the heart's not keeping up. So we have a fluid shift mechanism and we have hormones that alter. So these hormones alter in the kidneys, the pituitary gland, and the adrenals. This is just a brief overview of heart failure. You'll get a lot more of this in A&P, so this is just a brief overview. So principles of medical nutrition therapy, we want to reduce sodium. Remember, water follows sodium. So the more sodium somebody takes on, the more water that they retain. And if their heart's already tired and already can't keep up, more salt would become a higher problem for them. We also would want to restrict fluid. So imagine that heart is essentially drowning. It's congested. Putting in a lot of fluid gives it more work. So these patients are usually on fluid restriction. Doctor may request for dietary supplements and little or no alcohol. So that's more fluid, more stress on an already stressed heart. So these are some of the main key points to heart failure. All right, guys, we're moving into our next lesson, lesson 19.2 on hypertension. So hypertension is a chronically elevated blood pressure, may be classified as primary or secondary. Hypertension damages the endothelium of blood vessels, and early education is critical for the prevention of cardiovascular disease. So secondary hypertension differs from the usual type of high blood pressure, what we know as primary hypertension, which is often referred to simply as high blood pressure. So primary hypertension has no clear cause and is thought to be linked to genetics, poor diet, or lack of exercise and obesity. So we have differences between secondary hypertension and primary hypertension. Essential hypertension, this is our primary hypertension. So 30% of American adults have high blood pressure or hypertension. Risk factors include family history, obesity, smoking, age, ethnicity, physical inactivity, alcohol consumption, sodium intake, and chronic stress. Secondary hypertension is the result of another primary condition. So it's secondary. It's secondary to something else. So we have primary or essential hypertension, and then we have secondary hypertension. That's the result of another primary condition. Hypertension is called the silent disease. So we might not see anything when it comes to hypertension until it's very advanced. So hypertension is called the silent disease. So now we're going to look at hypertensive blood pressure levels. So normal blood pressure is systolic, so the top number less than 120 and the bottom number less than 80. Now patients can have pre-hypertension. So when they're pre-hypertensive, the doctor's going to have them focus on lifestyle changes, so diet, exercise, things like that. This is when the systolic is 120 to 139 and the diastolic is 80 to 89. If they don't make those changes, they can end up in stage 1 hypertension, and usually that's diet and where the doctor starts prescribing medications. So this is where the patient has a systolic of 140 to 159 and the bottom number, the diastolic, from 90 to 99. And if the systolic is greater than or equal to 150, depending on the age, so these are people who are 60 and older, or 90 to 99 for diastolic for that same age group, 60 and older. Stage 2 hypertension, this is going to be continued drug therapy, but now really aggressive drug therapy. So these are the patients that have the systolic greater than 160 and the diastolic greater than 100. So that would be stage 2 hypertension. I don't need you to memorize these numbers. I just want you to see as it gets worse, the therapy gets more intensive. You should be getting fairly familiar with these numbers from working in skills lab. So we have normal, we have kind of it just starting pre-hypertension, it's getting a little worse, stage 1, and then stage 2 where it's going to require really vigorous, usually with several medications, drug therapy. Principles of medical nutrition therapy for hypertension. So weight management, lose excess weight and maintain healthy weight. So that would be very important for these patients with hypertension. DASH diet. So DASH stands for Dietary Approaches to Stop Hypertension. We just know it as DASH diet, but that's what the acronym is, Dietary Approaches to Stop Hypertension. So of course that goes for this hypertensive patient. So this is lower blood pressure through diet alone. Sodium control, we want to limit sodium between 1,500 to 2,400 milligrams per day. There's a direct correlation between sodium intake and blood pressure. So higher sodium intake leads to high blood pressure. So picture that sodium, all the water following that sodium, all this swelling, all this extra pressure on the heart. We also have that pressure equaling a higher blood pressure. We see more traffic through those vessels. So this high sodium definitely leads to high blood pressure, even in patients with resistant hypertension. So there's some additional lifestyle factors like limiting alcohol. So already stressed hearts, adding a lot more fluid to it. Smoking, we've talked about how smoking causes vasoconstriction, so it causes more narrowing. Something patients can do is increase their exercise, as well as using stress management techniques. So these are all some principles that patients can utilize to help manage their hypertension. Education and prevention. So food planning and purchasing. So we always want to encourage our patients to read the labels and eat fresh foods with limited processed foods. So they should pick most of their foods from the fruits and vegetables aisles rather than the frozen foods. Food preparation, use less salt and fat. Use seasonings instead. So remember I mentioned that lemon is a great choice. And less animal products and smaller portions. So use less fat, use less salt. So things like pretzels that are very salty, patients would want to avoid that. Foods like French fries, definitely avoid that. Corn chips, all those high salt foods should be avoided. So when educating our patients, they really want to avoid those high salt foods. And a person-centered approach. Personal desires, ethnic diets, and food habits. If we don't treat our patients like individuals, they're definitely not going to be able to follow what we're saying. So we really want to focus in on them as an individual so that we're able to really make an impact for them. Education principles. So they want to start early. Prevention begins in childhood, especially with children in high-risk families. So we want to teach our children from an early age. That's the best time to start with prevention. We want to focus on high-risk groups. So direct education to people and families with risk of heart disease and hypertension. So if they're at risk, we really want to focus on that group of people. And use a variety of resources, including national organizations, community programs, and perhaps dietitians. So we want to utilize any resource that can really assist our patients. So I hope you all enjoyed this lecture. For me, lecturing on the heart is one of my favorite lectures. All my students know it from my previous groups. They know I love lecturing cardiac. I spent many years as a cardiac nurse in the hospital. So for me, it's one of my favorite subjects. There's usually some students that come out of Mod 1 where it's their favorite subject too. So hopefully there's some of you out there that really enjoyed this topic. Thank you guys. Have a great night or day.